I remain Adegoke Juliet Feolua. I've been your online facilitator for this course, and I took you in first semester. We started with the first episode in first semester, which is PHA 301, and this is the concluding part, PHA 302, Pharmacology and Chemotherapy. During the online facilitation, we had some series of study sessions that we discussed. We discussed the general principles of drug administration, which was in 2 parts. We also discussed calculation of drug dosages, the application of nursing process in drug administration, cardiovascular drugs. We discussed respiratory agents. Though during online facilitation, we were unable to discuss the thyroid agent, but I will just take you through a quick history into what is thyroid agent in case you meet it next time. But before we start, I would like to take you back to what pharmacology is. What is pharmacology itself? Pharmacology is a branch of medicine. As you all know, you have done that in first semester, but I just have to take you back to bring it back to your memory. Pharmacology itself is a branch of medicine, and it is concerned with the uses, the effects, and the mode of action of drugs. Pharmacology encompasses pharmacokinetics and pharmacodynamics. What do I mean by pharmacokinetics? It is what the body does to the drugs in terms of drug absorption, drug metabolism, drug distribution, and drug elimination. And what do I mean by pharmacodynamics? It is what the drug does to the body, how the drugs bind to receptors to carry out the therapeutic effect. That is the pharmacodynamics. I've been mentioning drugs. What is drug itself? Drug is a chemical substance which, when administered on a living organism, they produce a biological effect. Drugs are used to cure, they can be used to treat, and they can be used to prevent or even diagnose a disease condition. And that will now take us to principles of drug administration. There are some situations that require special consideration before you administer a drug. Example is sometimes probably the patient complains that, okay, I'm having nausea, I'm feeling dizzy, I'm having some ringing sensation in my hair, I'm having difficulty in walking. At this time, you have to take special precaution before you administer drugs to such patients. Or when you receive comments that the drug looks different from the one the patient has been previously received. Sometimes, though we can have changes in drugs, drugs come in different forms, depending on the brands. The brands can change, it can change in forms of color, it can change in forms of shape. Drugs can change. But most times when patient now tells you that, sorry, this drug is different from what I've been receiving, you have to take special precaution. You have to be sure, is this the drug this patient is supposed to take or not? So you have to take special consideration when you receive such statement. Or when patient thought that the primary care provider has discontinued the drug therapy. Most times, especially when you have elite patients on the ward, and during ward rounds, we discuss whatever form of care we want to give to the patient during ward rounds, independent of those patients. Sometimes they feel, okay, the primary care provider has discontinued this drug. Patients can raise it up when you have gone to them to administer those drugs. So when you receive comments like this, you have to take special precaution before you administer those drugs. By going back to confirm from the patient's case file, you go back and confirm from the primary care provider if actually the drug has been discontinued or not. And in another case where you have to take special precaution is when there's a change in patient condition. For example, when there are changes in the vital signs, when the blood pressure suddenly reduces suddenly, and you want to administer an antihypertensive, you have to take special precaution before you administer such drugs. You have to inform the primary care providers before you administer those drugs. Also, how do you prepare a drug for administration? Before you can prepare before you can administer drugs, there are some things that you must do. Those are what we want to consider now. The first thing is you always check the healthcare provider's written orders and you verify any question with the healthcare provider. Many a times, nurses act on voice notes, not just on written orders. This is very wrong. Your colleague cannot just tell you, okay, the consultant has placed this person on this drug. You have to confirm. It must be well documented before you administer those drugs. And you prepare the drug for administration in a quiet, well-lit area. The reason for preparing this drug in a quiet, well-lit area is just that to prevent, when it is not quiet, it causes distraction. And when you are distracted, you can make mistakes, you can make errors. The well-lit area, you must have adequate lighting, in the sense that you have to see what is written on the drug ampoules, you have to check the expiry date, the name of the drug. You have to check all those information before you can administer such drugs to patients. So you also always check the label of the drug 3 times. 3 times. The 3 times that the first one is immediately the drug is taken out from the storage area. You check the drug label to be sure that this is the actual drug you want to administer to your patient. You also check the second time immediately before removing the drug from the container. Okay, you have checked after removing it from the storage. You have to check before you remove the drug from the container. And the third time is before you return the drug back to the storage area. So you have to check the drug 3 times just to be sure that you avoid medication errors. Another thing is never remove a drug from an unlabeled container or from a container whose label is illegible. Never assume this injection is acetaminophen when it is not acetaminophen. We can have different injections that come in the same shape. You can have the diclofenac that comes in the same shape that acetaminophen will come. So you have to be sure, check that the label is very legible before you administer such drugs. And another point is you have to wash your hands immediately before preparing for drug administration. Drug administration should be a sterile procedure. Don't contaminate the drugs you want to administer to your patient. So you wash your hand to maintain aseptic techniques. After that, do not let them touch the capsule or tablets. Most times I get surprised when nurses want to dispense drugs and they put the drugs into their hands to dispense for their clients. This is very wrong. This is very wrong. If you want to take drug out from a container, you rather shake the amount of the capsule or the tablet you need to administer to your patient. You shake it into the cover of the container and you transfer it into the medication cup before you administer the drug to your patient. So don't let your hands touch the capsules or the tablets directly. Don't contaminate the drugs of your patient. The patient, they are observing you. Always observe aseptic technique when you're handling syringes and needles. Like I've said, drug administration must be a sterile procedure. You must maintain sterile aseptic technique. And you have to be alert for drugs with similar names. There are different drugs that have similar names, like digoxin, digitoxin. These drugs are of different brands. They are not the same thing. You have to observe. You have to be alert for drugs with similar names. Another thing is you have to replace the cap of drug containers immediately after you remove drug. Don't allow air to enter the container. It should be airtight. When immediately you remove the drug that you want to administer, immediately you remove it, make sure you cover the container back immediately. So also return drugs requiring special storage to the storage area immediately after they are prepared for administration. This refers to drugs like drugs that are stored in the refrigerator. You have to return them back immediately. We have insulin, we have some injections like that they are stored in they have special storage that they are stored in the fridge. You have to return them back immediately after they are prepared for administration. Another important thing is you should never crush a tablet. Never crush tablets or open capsules without first checking with the pharmacist. There are some conditions whereby you see tablet comes in coated forms. And there are reasons why it comes in coated form. It is not just for fashion. It is not just to beautify the drug. Most times, because of gastric irritation, because of the absorption of these drugs, they come in coated forms. So you have to check with your pharmacist, confirm with your pharmacy before you crush those tablets. Some of these tablets, when you want, especially the coated ones, when you crush them, it reduces the rate at which they are absorbed and can cause gastric irritation. So never crush tablets and open capsules. Some capsules, we have some nurses, they open capsules. So an example of drugs that comes in capsules are like Ampiclos, chloramphenicol capsules. When you open those capsules, sometimes it is not all those capsules, most of the powders, they don't dissolve well in water. So they have reasons why those that produce the drug why they have encapsulated the drug. So most times, don't open the capsules. I've seen people administering, okay, they will write, okay, they are prescribing 250 milligram of Ampiclos for children. When the manufacturer has known that when children want to use 250 milligram of Ampiclos, it should come in powder form, which they will have to suspend. So under no circumstance must you open a 500 milligram capsule and say you want to divide it into 2 to make 250 milligram. This is very wrong. So don't open capsules. Most times it obstructs their absorption. They are not absorbed well. Another thing is never give a drug that someone else has prepared. The individual preparing the drug must administer the drug. Because Nurse Lagbaja has closed for duty, the person has withdrew injection and is now telling you to administer the injection. Never. It is the person that has prepared an injection that must administer it. You have to be careful of medication errors. And this will take us to administration of drug by oral route. There are different routes of drug administration. We have discussed this in 4th semester. We give oral drugs to people that can swallow. It is very easy for people that can swallow and patients that are alert. What are the oral drug forms include tablets, capsules, and liquids. And what are your responsibilities as nurses? As nurses, you must place your patient in an upright position. This makes swallowing easy. Only on few occasions that you can give your patient drugs when the patient is not in upright position. For example, unconscious patients, when you want to give drugs through NG tube feeding, you can give drug. But when a patient, a normal patient, you don't give drug in an abnormal position. You place the patient in an upright position. You also ensure that you have a full glass of water. It allows for easy swallowing of the drug. Also, you assess the patient's need for assistance in removing the tablet or capsule from the container, or from holding the container, or from holding the medicine cup, or holding a glass of water. It is so surprising at times when you see nurses giving drugs to patients and say, okay, remove 2 tablets from that sachet and give it back to me. This is very wrong. There's need for you to assess this patient's need. Sometimes some of them need help. They need you to help them to carry the medicine cup. They need you to help them to carry a glass of water. That is why we are nurses. We have to show empathy. Don't be careless. So when you're administering drugs, check the patient need for assistance. Another point is you advise the patient to take few sips of water before placing the tablet or the capsule in the mouth. This allows for easy facilitation of swallowing of this drug. Also, you give the patient any special instruction, such as drinking extra fluid, or you remain in bed after you have swallowed this drug. You have to give them instructions. There are different drugs, and they have special instructions that are pertinent to them. Another thing is you never leave a drug at patient bedside to be taken later, unless there's specific order by the primary care provider to do so. Though there are some drugs that you can leave at the patient bedside, but normally you should not leave drugs at the patient bedside. Sometimes when you have a patient on antacids, you can sometimes, because it's PRN, you can leave some of these drugs beside the patient, but it is not normal. most times to leave to leave drugs beside the patient. Then when you want to administer drugs to parenteral route, by parenteral route, I mean drugs that you give either by subcutaneous route, intramuscular route, intravenous route, intradermal route. And when you give such drugs, they are referred to parenteral drugs. There are some core responsibilities that are expected of you as nurses. The first one is you wear gloves for protection. This will protect you from potential of blood spill when you are giving parenteral drugs. Even according to Center for Disease Control, it is expected that you wear gloves when you are touching blood or body fluids or mucous membranes or any broken skin area. You have to ensure that you protect yourself. And this recommendation is referred to what we call as standard precaution. Another responsibility is after selecting the site for injection, especially in intramuscular injection, you have to clean the area. You have to clean the skin with an antiseptic lotion so that you will not contaminate the injection, the drug you want to give. After inserting the needle for intramuscular administration, you pull back the syringe barrel to aspirate the drug. And most times when you insert your needle, you have to check if the needle is inside the muzzle, especially for high hem, or inside the blood vessel. That is why we check and see if blood is coming out. If blood is coming out, you have to remove that needle and start all over the process. You have to restart the process all over again. You must not withdraw blood. Also, do not recap syringes and you have to dispose them according to agency policy. Because more than 80% of needle stick injuries, they could be prevented when you practice saver needle devices. Do not recap syringes, you dispose them. There's always a safety box where you have to dispose your needle immediately after use. Never try to recap them, because by the time you try to recap, you are exposed to needle stick injuries. Needle exposures can transmit diseases such as hepatitis B, hepatitis C, HIV, human immunodeficiency virus, and other infections, according to research, that can be transmitted through needle stick injuries include tuberculosis, syphilis, malaria, and so on. What are your responsibilities when you are administering drugs by the subcutaneous route? By subcutaneous injection, that means you have to place the drug into the tissues between the skin and the muscle. And drugs that are administered through subcutaneous injection, they are usually absorbed more slowly than the intramuscular injection. Heparin and insulin, they are the most commonly used drugs that are given subcut. A volume of 0.5 to 1 ml is usually used for subcut injection. The larger volumes, like 1 ml and above, they are best given in intramuscular injections. The sites for subcut injection are usually the upper arm, the upper abdomen, the upper back. And when you are giving a drug by subcut route, you have to insert the needle at 45-degree angle. Meanwhile, for intramuscular injection, you insert the needle at 90-degree. However, in some cases, when you are giving subcut injection, especially when you have obese patients, when they have excess subcut tissue, it may be necessary for you to still give this injection at 90-degree angle. But when the patient is thin, or when they are cachetic, when they have cachetic tissues, they usually have less subcut tissues. In such patients, you give these subcut injections in the upper abdomen or in the best, which is the best site for this injection. Administration of drugs by the intramuscular route. If an injection is more than 3 ml, you have to divide the drug. Many nurses, you see them giving IM injection of a 5 ml drug. This is not right. Anytime your injection is more than 3 ml, you have to divide this drug into separate injections, because a volume larger than 3 ml will not be absorbed properly. Also, when you are giving drug by hair-hem route, like I've said earlier on, you insert the needle at 90-degree angle. The Z-track method of hair-hem injection is usually used when a drug is highly irritating to the skin tissues, or when they have ability to permanently stain the skin. Example is when you are giving iron dextran injection. They have ability to stain the skin. So you use this Z-track method. And what does it entail? You place the patient in a correct position for administration of this IM injection. Make sure that the site you want to administer the injection to is well exposed, and the patient is also positioned well. You have to clean the skin with lotion to clean the skin. Make sure the skin is sterile. You pull the skin, you put the subcutaneous tissue and fat laterally, and you displace the tissue to the side. After the drug is injected, you release the tissue and you withdraw the needle. This technique will prevent the backflow of the drug into the subcutaneous tissue. Drugs that are given by IM injection, they are usually more rapidly absorbed than drugs given by subcutaneous injection because of the rich blood supply in the muscle. Administration of drug by intravenous route. We are all aware of intravenous route. When you are administering a drug into the vein by venipuncture, you as a nurse, you should place the tourniquet above the selected vein. It is, however, important for you to tighten the tourniquet so that venous blood flow is blocked and arterial blood flow is not. You as a nurse, you should allow the veins to fill. That is when you see it distended. Then you pull the skin out and insert the needle into the vein. You bevel up at a short angle to the skin. Then blood should immediately flow into the syringe if the needle is properly inserted into the vein. Depending on your clinical judgment, when you have practiced 3 unsuccessful attempts as a nurse on the same patient, it warrants you to call for more skilled individual to attempt the procedure. Many attempts, in an attempt to give intravenous injection, you see nurses pricking patients, trying about 5, 8 attempts unsuccessfully. This is not right. This is not ethical. So when you have tried about 3 unsuccessful attempts, you have to look for more skilled personnel to try the procedure. And when you see swelling around the needle, most times it can indicate 2 things. It is either extravasation or infiltration. What do I mean by extravasation? Extravasation refers to the escape of fluid from blood vessel into the surrounding tissues while the needle is still in the vein. Meanwhile, for infiltration, it is the collection of tissue or fluid in tissues, usually the subcutaneous tissues, especially when the needle or the catheter is out of the vein. When you have 2 of these cases, either extravasation or infiltration, what do you do as nurses? You have to discontinue this line. You have to discontinue the infusion and you insert another IV line into another vein. Other route of parenteral administration or other route of drug administration. Intradermal route, you can have topical route, transdermal route, and inhalational route. There are some special considerations when you're administering drugs. There are some important people that you have to consider when you're administering your drug. The first set of people are the pediatrics patients. I mean, the little children. You have to consider them because physiologically, their body system is not mature, which may make the drug to be less predictable, the drug effect to be less predictable. Also, as pediatric patients, they require dosage adjustment, whereby you need to calculate and carefully measure the doses. Also, you have to observe pediatric patients closely for adverse effects and drug interactions. Then administration sites for pediatric patients and the techniques you use to administer drugs, they may differ. Another set of people that you have to consider when you're administering your drug are pregnant patients. When you see a pregnant woman, bear it in mind that you are caring for two patients. You are caring for both the mother and the fetus. So you have to give the mother, always know that the drug that you give to the mother means that you are also giving the same drug to the baby. So when you see pregnant patients, you have to check drug information sources for pregnancy drug risk categories. Another set of people you have to consider are the breastfeeding mothers, lactating mothers. Some drugs are excreted in breast milk. Also, ingestion of drugs can be dangerous because the baby may not be able to metabolize or excrete these drugs. You have to check drug information sources for contraindication during lactation. Another set of people are the elderly patients, aged. Because of age-related changes, it affects drug absorption, it will affect drug metabolism, it will affect drug distribution and drug excretion. Don't forget, that is pharmacokinetics, which I have discussed earlier on. So elderly patients are another set of people that you have to consider because there could be increased risks of drug toxicity. There could be adverse effects and lack of therapeutic effects. Let me cite an example. Sometimes when you see an aged patient that you want to place on an anti-malaria, I hope you all know that anti-malaria drug is given based on the weight of the patient. Sometimes, for the commonest example, we have the artemether that comes in 4 tablets. That's the commonest example. When you have this type of drug, this artemether that comes by 24, sometimes you can have aged patients that may not be able to take the complete 4 tablets because of their weight. Because most of them, they don't have enough subcutaneous tissues. So when you see elderly patients like this, you have to calculate their weight and consider their weight and their condition before you administer those drugs to them. What are the nursing responsibilities regarding drug administration? Nurses are legally and morally responsible for correct administration of medication. And when it comes to medication errors, it is your duty to avoid medication error because you are in between the drug and the patient. So when you are in between the drug and the patient, anytime medication error occurs, it is most times the fault is usually put on the nurses because you have a role to play not to avoid this medication error. So as a nurse, when you are administering drugs, you have to follow institutional policy. Each institution has their policy concerning drug administration, and it is also your role, it is your responsibility to ensure that patients comply. So you foster compliance. That is why you are with the patient 24 hours. Because most times when they are at home, they fail to comply to this drug regimen. So it is part of your responsibility as nurses to ensure that patients comply to their drug regimen. And another thing is you correctly document all actions which are related to medication administration and medication errors if eventually they occur. You must evaluate and record patient responses to drug using your vital signs that you normally carry out. So you have to evaluate your patient's response to drug. Also, you have to observe adverse reactions. You have to observe that is why you must have the knowledge of pharmacology. It is the knowledge of pharmacology that will tell you what could be the adverse reaction of each drug. What are the likely side effects that you can encounter when you administer those drugs. So without that knowledge, you may not be able to observe those adverse effects. And that is the reason why you are studying this course. And as a nurse, you must record all suspected adverse reactions and report them to the primary care provider, which is usually, in most cases, the medical team. And that will take us to calculation of drug dosages. What do I mean by calculation of drug dosages? There are 3 systems of drug measurement. When I say systems of measurement, it refers to collection of units of measurement and rules that are relating to each other. There are three systems of drug measurement: the metric system, the apothecary system, and the household system. The metric system is the most commonly used system, and it is the most preferred by pharmacists. Although the apothecary system has been was in use, they were formerly using it. But however, it is no longer in use, but sometimes you might come across this apothecary system of drug measurement. It has been largely replaced by the metric system. And the household measurement, they are the ones we use in our house. It is usually not accurate. And that is why you don't usually use it in the hospital. But however, you have to use it when you are discharging your patients, when you are discharging them home. The metric system uses decimals. The gram is the unit of the weight, the liter is the unit of the volume, and the meter is the unit of the length. So that is one thing about the metric system. It measures weight, it measures volume, and it measures length. Unlike the apothecary system, it measures only the weight and the volume. It does not measure length. The apothecary system uses whole numbers and fractions. The whole numbers are usually written in the lowercase Roman numerals. For example, when you use small x instead of 10, and when you use V in lowercase instead of 5, don't forget your Roman numerals. Then the unit of weight in the apothecary system are the grains, the drams, the ounces, while that of the volume are meanings, free drams, and free ounces. Therefore, the household measurement, they are for volume only. That is why I said you use it at home when you are discharging your patient home. In the hospital, household measurements are rarely used because I said they are inaccurate when used to measure drugs. I'll give you, on your screen is the metric system measurement. Like I've said, it measures in length, it measures weight, and it measures volume. For the length, you can say 1 meter is equal to 1,000 millimeters, and 1 meter can be equal to 100 centimeters. 1 kilometer is equal to 1,000 meters, and 1 decimeter is equal to 1/10 meter, that is 0.1 meter. Using the metric system to measure weight, 1 gram is equivalent to 1,000 milligrams, and 1 kilogram is equivalent to 1,000 grams. Then the liquid for the volume, using the metric system, 1 liter is equivalent to 1,000 milliliters, and 1 deciliter is equivalent to 1/10 liter, that is 0.1 liter. And that will take us to the apothecary system of measurement. It measures in volume and in weight. So you have the system of measurement where you have 60 millimeters is equal to 1 Fluid gram, and 8 Fluid gram will be equivalent to 1 fluid ounce. 16 fluid ounce is equivalent to 1 pint, then 2 pints is equivalent to 1 cat, and when you have 4 cats, is equivalent to 1 gallon. For the weight, I said you measure it in grains. 20 grain is equivalent to 1 scruple. You have the symbols displayed on your screen. 3 scruples can be equivalent to 1 drachm, and the 3 scruples is equivalent to 60 grains. 8 drachms, which is 480 grains, is equivalent to 1 ounce, and 12 ounce is equivalent to 1 pound. So you should be familiar with this system of measurement, so that when you come across this measurement, you'll be able to put the equivalent and carry out your calculation. We can have the metric and apothecary system equivalent, in the sense that when you have 1 milligram, it is equivalent in the apothecary system of measurement to 1/64 grain. When you have 1 liter, is equivalent to 1 cat. And for 1 grain, that is the measurement in weight of the apothecary system, is equivalent to 65 milligrams of the metric system. For the minimum in the apothecary system, it is equivalent to 0.064 in the metric system. So you have the equivalent. And that will take us to the household system of measurement. Like I've said, it is usually used at home. It is used for volume. When you are discharging your patient home, you can tell them, okay, you measure this drug in tablespoon, or you measure this drug in teaspoon. We are used to drop, which we normally abbreviate as GTT, that is drop. So for 1 teaspoon, it is usually equivalent to 60 drops. And when you are using tablespoon, it is usually equivalent to when you are using tablespoon, 1 tablespoon is equivalent to 3 teaspoons. When you are using cup, your 1 cup in household measurement is equivalent to 8 ounces. And when you are using gallon, your 1 gallon is equivalent to 4 quarts. So I would advise you to take your time and see these various measurements. You can do conversion between systems, especially when I was discussing about the special consideration you have to take in pediatric patients, in aged. Sometimes you just have to do conversion between systems. Drugs can come in one system and you want to use another system to apply, to administer the drug. For example, when you want to change a drug, when you see it coming in ounce and you want to change it to gram, what do? You multiply simply by 28. When it is to change a teaspoon to milliliters, you multiply by 5. To change tablespoon to milliliter, you multiply by 30. The most common one is the temperature. Temperature comes in Fahrenheit, it can come in Fahrenheit and it can come in Celsius. To convert from Fahrenheit to Celsius, what you do is you multiply by 5/9 after you have subtracted 32. It will give you equivalent of the temperature in Celsius. Now we are moving on to application of nursing process in drug administration. Nursing process is used in all areas of nursing endeavor. And nurses, we have complex and many roles when we are administering drug, the safety net in between the drug and the patient. So you are in charge of preventing medication errors. So nursing process, as you all know, you are all familiar with nursing process. It's just a framework for nursing action, which you have to consider, which consists problem-solving steps that will help you as healthcare worker to provide effective patient care. Nursing process has 5 phases. And in this course, we are discussing nursing process only in regard to drug administration. It has 5 processes. We have the assessment phase, we have the diagnosis phase, we have the planning phase, we have the implementation phase, and we have the evaluation phase. And what do you do in these phases? Looking at the diagram on your screen, in the assessment phase, what is expected of you? You carry out both initial and ongoing assessment. And how do you do this? You have to collect both subjective and objective data. What is the difference between objective and subjective data? Objective data are what you see. An example of objective data is blood pressure that you have taken from a patient is an objective data. The pulse you have taken from a patient is an objective data. The respiratory rate is an objective data. Because you have seen this, they are objective data. And what do I mean by subjective data? They are just data that require initial assessment by obtaining information from the patient, such as family history of disease, history of allergy, and so on. So those are the things you do when you are carrying out your assessment. Then you now move to nursing diagnosis. In nursing diagnosis, I hope you know that nursing diagnosis is different from medical diagnosis. In nursing diagnosis, it involves description of patient problem and their probable or their actual related causes, which should be based on subjective or objective data. In carrying out nursing diagnosis, the most common nursing diagnoses in drug administration include ineffective therapeutic regimen. We can have deficient knowledge, non-compliance, anxiety, and you can have many other nursing diagnoses. But your nursing diagnosis is not complete if you don't relate it to a cause. You must relate your nursing diagnosis to a cause. That is when it will give you a complete nursing diagnosis. Then you now move to planning. After your nursing diagnosis has been formulated, you as a nurse, you are expected to develop outcomes, which will be patient-oriented. An expected outcome is just a direct statement of a nurse-patient goal, which should be achieved. The expected outcome describes the maximum level of wellness that is reasonable, that is reasonably attainable for the patient. So in planning phase, you set your expected outcome. You develop a teaching plan to correct deficient knowledge. If your nursing diagnosis is deficient knowledge, for example, so you set a teaching plan to correct the diagnosis you have made. And if it is non-compliance, you have to set your target on how you want to ensure that this patient comply with the drug regimen. And that will take us to the next phase, which is the implementation phase. Implementation is just carrying out a plan of action and is a natural outgrowth of assessment and planning phases of the nursing process. In implementation phase, you have to perform the nursing action before administering the drug. And you have to administer the drug according to the 6 rights. It depends on the text you are using. There are different perspectives to this right. You can say we have 4 rights. You can say some texts will tell you we have 6 rights. Some texts will tell you we have 8 rights. But these rights they are talking about include the right patient, the right drug, at the right dose, the right time, for the right reason, observing the right response, and the right documentation. So there can be different, it depends on your school of thought. So these rights, you must implement them. And you have to, in the implementation phase also, you have to manage adverse reactions. You teach patients or family about the drug, the disease process, and the treatment regimen. And that will take us to the evaluation phase. And what do you do in the evaluation phase? It involves you monitoring your patient responses to these drugs. You monitor the expected and the unexpected responses. In the evaluation phase, you evaluate the effectiveness of the nursing intervention. If it has met the patient, the expected patient outcome. You evaluate your effectiveness of the drug regimen. Okay, you are administering this drug to reduce pain. Has it actually reduced pain? So you evaluate, you carry out this during evaluation phase. You evaluate patient or family understanding of the drug regimen. However, each patient is an individual, and nursing care must be planned on an individual basis after careful collection and analysis of data. And this will take us to this will take us to cardiovascular pharmacology. Cardiovascular disease, we are all familiar with cardiovascular disease. We are all nurses, so we are familiar with cardiovascular diseases. Cardiovascular diseases includes heart diseases, arrhythmias, hypertension. And as we all know, hypertension, all these cardiovascular diseases, their morbidity and their mortality in the Western world. There are numerous devastating conditions affecting the heart. And apart from the heart, they can affect the vessels of the heart. And with this increase, it has led to increase in demand of cardiovascular drugs. The cardiovascular pharmacology deals with the study of effect of drugs upon the heart or the circulatory system. These drugs affect the function of the heart in 4 ways. When you are giving patients some cardiovascular drugs, it will rather come out, it affects the heart in 4 ways. The first one is it may affect the force of contraction of the heart, which is known as inotropic effect. It may affect the frequency of the heartbeat or the heart rate. It will rather increase or decrease the heart rate. So this is known as chronotropic effect. And they can affect the regularity of the heartbeat. And that is what we know as rhythmic effect. They can also affect the blood vessels, either by altering the state of compression of the smooth muscles in the vessel walls, or to alter the diameter and the direction of the volume of the bloodstream. So this one will come as vasodilators or vasoconstrictors. So cardiovascular drugs works in 4 ways. They can produce inotropic effect, they can produce chronotropic effect, they can bring rhythmic effect, and they can act as vasodilators or vasoconstrictors, depending on the smooth muscle lining they are working on. What are the classification of these cardiovascular agents? During the online facilitation, we are able to discuss many of these cardiovascular agents as alpha blockers, angiotensin converting enzyme inhibitors, that is ACIs. We have antiarrhythmic drugs. We have anticoagulant, antiplatelet, and thrombolytic drugs. We have beta blockers too. We have calcium channel blockers. We have centrally acting drugs. We can have cholesterol lowering agents, digitalist drugs, diuretics, nitrates, peripheral adrenergic antagonists, and vasodilators. You all have these in your manual. We'll go into the mechanism of action. I'll just describe the mechanism of actions of each of these classification of drugs, and we'll give you examples. The first one is the alpha blockers. The alpha blockers block nerve receptors, and they are called alpha receptors. From the word alpha blockers, it means they block alpha receptors. What is the work of these alpha receptors? Alpha receptors are mostly involved in stimulation of effector cells and constriction of blood vessels. So by the word alpha blockers, it means they will block the effect of alpha receptors. And I said alpha receptors are responsible for constriction of blood vessels. So what do I mean? It means alpha blockers will bring about vasodilation of the blood vessels, and eventually it will bring about lowering of blood pressure. And this will also reduce the workload of the heart. So the mechanism of action is very easy to understand. From the word alpha blockers, it means they block some nerve receptors, which is the alpha receptor. So you have to know what this receptor, what is it that they do? What is their responsibility? That is when you can be able to explain mechanism of action of these drugs. So for the alpha blockers, example of alpha blockers are doxazosin, prazosin, terazosin. And they come in tablets, they come in capsules, like that. In general, the alpha blockers, they are not as effective for initial therapy as some of other blood pressure lowering drugs. So we also have alpha and beta blockers in combination. That means those drugs, they block both alpha receptors and beta receptors. We have beta 1 and we have beta 2 receptors, depending on where they are. The beta 1 are usually located in the heart, in the muscles of the heart, where the beta 2 blood receptors, they are usually found in the lining of the bronchi and the lungs. So when we have alpha and beta 2 blockers, the example of alpha and beta 2 blockers is labetalol. Labetalol comes in tablet and it can come in injections. So, but labetalol should be used in caution by people with lung problems. It should be used in caution with people with asthma. It should be used with caution with people having diabetes. That is why you have to carry out complete assessment of your patient before you start prescribing drug or administering drug. So you have to take history. Is this patient an asthmatic patient? For an asthmatic patient, you don't prescribe alpha and beta blockers because it will aggravate the constriction. Because I said the beta blockers, the beta receptors, the beta 2 receptors especially, is found in the bronchi. So they cause vasoconstriction. And when they cause vasoconstriction in an asthmatic patient, you don't administer beta blockers. So you have to take caution. So for you to know what cautions to take, that is why you should be familiar with your MDEX. Nurses have MDEX that will guide you about drug indication, drug contraindication, the side effect, and so on, and also the dosages. For people with diabetes, when you administer beta blockers, it will block the release of insulin, whereby it will interact, thereby interacting with the nerve signals in the pancreas, and this will lower insulin levels, even when the blood glucose is high. That is why you have to be careful when you're administering alpha and beta blockers. Another group of drug is the ACE inhibitors. The ACE inhibitors act to prevent production of hormone, the hormone angiotensin II. And the ACE inhibitors act to prevent production of hormone angiotensin II, which constricts blood vessels. The angiotensin II hormone, they are usually they are found in blood vessels, and they cause vasoconstriction of these blood vessels. So the ACE inhibitors will have to prevent this vasoconstriction. So when you give these drugs, they act as vasodilators because they are preventing the effect of the hormone angiotensin II. It will thereby help them to, it will help the blood vessels to dilate. So that means they act as vasodilators, and it is usually effective to lower blood pressure. Example of these ACE inhibitors is captopril. We are all aware of captopril, lisinopril. So they have some side effects which you have to understand before prescribing to your patient. For example, a side effect of lisinopril can be dry cough. So when you place patient on lisinopril and they come back to you that they are having dry cough, you have to take your history, carry out assessment, and know what drug they are on before you take action. Sometimes when you withdraw this drug, the side effects will stop. So I'll refer you to your lecture notes to see most of these side effects. Another group of drug is the antiarrhythmic drug. This drug acts to correct irregular heartbeat, and heartbeat that is beating too fast. Example of this antiarrhythmic drug include amiodarone. It comes in tablets. And digoxin is very common. That is the commonest one that we use. It's an antiarrhythmic drug. Digoxin comes in tablet. It can come in capsule. I hope you know it also comes in injection. Another antiarrhythmic drug is also lidocaine. We can have flecainide, perferon. All these are antiarrhythmic drugs. All they do is to regulate the heartbeat. Another class of drug is anticoagulants, antiplatelets, and thrombolytic drugs. When you say anticoagulants, that means it prevents coagulation of blood in the vessels. The antiplatelets, they have the thrombolytics. So this drug, they are sometimes referred to as blood thinners because they will inhibit the ability of the blood to clot. They prevent clots from forming in the blood vessels and from getting bigger. You know, when clots form in the blood vessels, is known as atherosclerosis. It can most times lead to patients having heart attack and so on. So example of the anticoagulants and the platelets and the blood thinners entirely. We have aspirin, we have dipyridamole, and warfarin. Warfarin is common, aspirin is common. That is why most hypertensive patients, you find them on low dose aspirin, which comes in forms of the commonest is the vasopressin that we give patients. Most times the anticoagulants, they are usually prescribed for patients who develop thrombophlebitis. That is inflammation of the veins in the leg or in the pelvis. So you give anticoagulants like warfarin to them to prevent coagulation of blood. And one of the dangers of this condition is that when you start patients on anticoagulants, you have to make sure that they have to be on this drug for a long time. That is most reasons doctors don't usually start them on anticoagulants because they have to stay on it for a long period of time. Another class of cardiovascular drug is what we call beta adrenergic blockers. We have discussed beta blockers and alpha blockers. So we have drugs can come, the cardiovascular drugs can come in form of beta blockers alone, or they can come in form of both beta and alpha blockers. I've told you where we have the beta receptors. I said we have beta 1 receptor, we have beta 2 receptor. You can have beta 1 receptor in the muscles of the heart. and where you can have the beta-2 receptors in the lungs or the lining of the bronchi. So example of these beta blockers are the atenolol, propranolol, acetobutolol. So if you are not familiar with any, you should be familiar with propranolol. Another class of drug is the calcium channel blockers. We all know that calcium is important for the muscle cells. So calcium channel, the calcium, when we have calcium in the blood, it prevents muscles of the arteries from constricting. So by blocking the passage of calcium into the muscles, so calcium channel blockers block the passage of calcium into the muscle cells, we thereby allowing free flow of blood in the blood vessels. So example of calcium channel blockers, the commonest one we know is nifedipine. You see patients on nifedipine, and nifedipine comes either in 20 milligram and it can come also in 30 milligram, depending on the manufacturer. Then we can have sexually acting drugs. These drugs, they act on the brain centers, and they will act to reduce nerve impulses, thereby constricting blood vessels. Example of these sexually acting drugs, they are clonidine and methyl dopa. Sexually acting drugs, they are not widely used in initial treatment of high blood pressure. But in most cases, you see people are abusing methyl dopa. That is Adomate, is usually Adomate. So you see them, but they are not to be used as initial treatment of hypertension. Instead, they are given, you can give them along with other drugs like diuretics, or you can also give them along with other drugs like other antihypertensives to produce enough reduction in blood pressure. The methyl dopa comes in 250 milligrams. So depending on the blood pressure of the patient, you adjust the dosage. Another class of cardiovascular drugs is cholesterol lowering agents. This drug acts to reduce elevated levels of cholesterol and or other blood fats. We have the HDL, we have the LDL, we have the triglycerides. These are the cholesterol found in the blood. However, before you administer cholesterol lowering agent, the first thing you do for elevated blood cholesterol is to improve the diet of your client. The first thing you introduce is diet low in saturated fat. Before you now think of these drugs, because when you place patients on cholesterol lowering agents, they have to be on it for a very long time. So before it is usually the last choice. So before you place them on, you have to regulate their diet. You have to encourage them to reduce their weight, to carry out moderate exercise, to stop smoking if the patient is smoking, and to reduce excessive alcohol intake. So most times, it is usually an adjunct to diet therapy, the cholesterol lowering agent. An example of this cholesterol lowering agent is cholestyramine, cholestyramine, and statins. Another class of cardiovascular agents is diuretics. Diuretics are usually known as water pills, and they act by increasing the kidney excretion of sodium and water, which in turn reduces the volume of blood, thereby reducing the blood pressure. And there are different types of diuretics. Depending on the site of action, they are classified according to their site of action. Like I've said, they can be classified as thiazide diuretics. For the thiazide diuretics, they work in the tubules. And we have loop diuretics. The loop diuretics, they are more potent than the thiazide diuretics, and they work in the loop of Henle. We also have potassium sparing diuretics. This one, they work in area where potassium is excreted in the kidney. That is why they are potassium sparing, and they prevent excessive loss of potassium that sometimes occur with the thiazide diuretics. And most times, these diuretics, they are usually given in combination with other antihypertensives. You can go back to your lecture notes and see different examples of diuretics. Another class of cardiovascular agents are nitrates. Nitrates are potent vein and artery dilators, causing blood to pool in the veins and the arteries to open up, thereby reducing the amount of blood returning to the heart. This has the effect of decreasing the work of the left ventricle and lowering the blood pressure. The commonest example of nitrate is nitroglycerin, and nitroglycerin is usually given to patients sublingually. You give it under the tongue. It acts very fast because they dilate the blood vessels to lower blood pressures. Another class of cardiovascular agents is the peripheral adrenergic antagonist, which lower blood pressure by inhibiting the release of adrenaline or by blocking the effect of adrenaline on the nerve endings and result into blood vessel dilation. You all know that adrenaline will cause vasoconstriction. So when you have when it is being inhibited, you have dilation of the blood vessel. An example of this peripheral adrenergic antagonist is the reserpine. And the last but not the least is vasodilator. As from the name, as their name indicates, they lower blood pressure by opening up or dilating arteries, thereby facilitating blood flow through them. Example of vasodilator is hydralazine, which is also known as apresoline. It comes in injection of ampoules, and it also comes as a powder form. We also have combination of drugs. Most times, most cardiovascular drugs, they work in combination. They work best in combination. So for physicians, they may prescribe several combination of drugs. And what is the advantage of this combination of drugs? The convenience is the major advantage to combination therapy. Because when patient is supposed to use about 2 or 3 drugs and is well combined in a pill, it is very convenient for the patient to use, and the patient will comply the more. So that is why I said convenience is a major advantage to combination therapy. Also, for combination drugs, it is usually less expensive than purchasing these drugs separately. The commonest example of the antihypertensive combined therapy is moduretic. That is combination of amiloride and hydrochlorothiazide. So we have many patients on moduretic, and with your knowledge of cardiovascular drugs, you should know why this patient is actually on moduretic. So it combines amiloride and hydrochlorothiazide. We can also have combination drugs in form of tenoretic, which combines atenolol and clothalidone. It can come in form of capozide. Capozide contains captopril and hydrochlorothiazide. And you can have Combipress, which is a combination of clonidine and clothalidone. We can have Regloton, which is a combination of clothalidone and reserpine. We can have Vaseretic, which is a combination of enalapril and hydrochlorothiazide. We can also have Apreside. Apreside is a combination of adrenaline and hydrochlorothiazide. So most times as nurses, when you come across these cardiovascular drugs, take your time to study the content of this drug, know the classes of this drug. That is why as nurses, even on the ward, you should go along with your nurses, your MDEX. It will help you, it will increase your knowledge of these drugs. When you have the knowledge of this drug, when you know the class they belong, it will help you to know, is this the drug that they have written for this patient, is it the right drug or not? And that will take us to respiratory agents. Drug used in respiratory problems can be classified into, we have oxygen. You wonder why I said oxygen is a drug. I will tell you later. We have oxygen, we have respiratory stimulant, we have expectorant, we have cough suppressant. In many cases where you have airflow obstruction, you can use beta-2 adrenoceptors agonist or stimulant. You can use theophylline and other xanthine derivatives. You can use mast cell membrane stabilizers. You can use corticosteroids. You can use anticholinergics. I will take this drug one after the other. Starting with the beta-2 adrenoceptors agonist. You know, I said we have the beta receptors. We have beta-1, we have beta-2. So the beta-2, like I've said earlier on, that it is found in the lungs, in the bronchi, in the walls of the bronchi, and so on. That is why drugs used for respiratory, you can classify them as beta-2 adrenoceptor agonist. Example of this drug include salbutamol. We are all familiar with salbutamol, also known as Ventolin. We can also have tabutalin, phenterol, isoetarine, rimiterol, and repoterol. All these are examples of beta-2 adrenoceptor agonists. Agents such as salbutamol, they are selective stimulants of beta-2 receptors. That is why they work with the respiratory system. They act on these receptors in the bronchi and in the small airways. They act on the mast cells, thereby causing relaxation of the bronchial smooth muscles and also causing stabilization of the mast cell. The route of administration is inhalation. Salbutamol is best given by inhalation because it will permit direct delivery of the drug to the site of action. Another reason why it is best given as inhalation is because it will reduce the possibility of a general or systemic side effects. Salbutamol can also come as it can also be given orally. It comes in forms of tablets, it comes in syrup. But when you give it inhalation now, it has rapid onset of action and it provides large surface area for absorption. The side effects of salbutamol include tremor, tachycardia, hypokalemia. These drugs are usually indicated in patients with asthma and COPD. COPD is chronic obstructive pulmonary disease. Salbutamol has a relatively long duration of action of about 4 hours or even longer. And that will take us to theophylline and other xanthine derivatives. These are also used in respiratory disorders. And what is the mechanism of action? They act by inhibiting phosphodiesterase and thereby increasing cyclic AMP by blocking the enzyme that breaks down the nucleotide. Increased cyclic AMP reduces the tone in the bronchial smooth muscle, thereby stabilizes the mast cell. So when we have increased cyclic AMP, it will lead to smooth muscles relaxation. Cyclic AMP, for AMP means adenosine monophosphate. So this drug acts by increasing cyclic AMP, which will bring about smooth muscle relaxation. And what is the clinical uses of theophylline and other xanthine derivatives? It is used orally in long-term treatment of asthma and chronic obstructive airway disease, especially in patients who show response to it. Example is aminophylline. We are all familiar with aminophylline. Aminophylline comes in tablet and it comes in injection. So you can give it orally and you can give it intravenously. What are the adverse effects of this drug? It can result into tachycardia. It can result into palpitation, at very high doses. You can have nausea, you can have vomiting, you can have diarrhea at high therapeutic doses, and convulsions too can be associated with it. That will take us to mast cell membrane stabilizers. Example of this include ketotifen. That is we can also have sodium chromoglycate. That's an example of mast cell membrane stabilizers. They are not usually common, but I've come across ketotifen once. What is their mechanism of action? They prevent bronchoconstriction in patients with extrinsic allergy. That is people with allergic asthma, which can be caused by either pollen and allergic agents. They stabilize sensitized mast cell and they inhibit the release of bronchoconstrictor agents like the histamine, serotonin, and other leukotrienes. These mast cell membrane stabilizers, they are administered locally to the lungs, either by inhalation as powder or from a pressurized aerosol or nebulizers. And part of their side effect is sedation, dry mouth that result from additional antihistamine effect of these drugs. Another class of drugs that you can use as respiratory agents are corticosteroids. Corticosteroids, they act as anti-inflammatory. They help by reducing mucosal edema, thereby increasing airway flow, and they modify the immune response and stabilization of mast cell. They also act by increasing beta-2 receptor responsiveness to the agonist. Route of administration is inhalation. It can be intravenously. Example of corticosteroid is hydrocortisone. We are all familiar with hydrocortisone. So it can be classified as a corticosteroid. So another drug used in respiratory disorder is anticholinergic drugs. Example of this drug is ipratropium. And how do they work? They work by blocking the action of acetylcholine. Acetylcholine is a neurotransmitter. Thereby, they will inhibit involuntary muscle movement in the lungs. What acetylcholine does is to increase voluntary movement, involuntary movement. So they increase involuntary movement. So these drugs, the anticholinergic, they will now work by inhibiting or blocking the action of this neurotransmitter acetylcholine, thereby inhibiting involuntary movement. So by the way, they will reduce spasm in the smooth muscles of the bronchi. What are the side effects of this drug? It can result into confusion, there can be hallucination, there can be drowsiness, then we can have dry mouth, blurry vision, and so on. Oxygen. Like I said earlier on, that oxygen is also a drug that you can give to patients with a respiratory disorder. How is it a drug? It is a drug when it is given to supplement the amount of air that is normally present in the inspired air. That is when it is regarded as a drug. And oxygen comes in two forms. It's either it comes in high concentration or in low concentration. For the high concentration, it is usually given to hypoxic patients. And any apparatus that you use to give oxygen at a rate of 5 liters per minute or more can be said to be a form of high concentration delivery of oxygen. And indications of high oxygen concentration is when patient has pneumonia, patients with acute pulmonary edema, patients with pulmonary thromboembolism, or patients with status asthmaticus. You can give low oxygen concentration, is usually reserved for patients with exacerbation of COPD with respiratory failure. So when oxygen delivery is less than 35%, it is usually low concentration of oxygen. And when you give it at a rate of more than 60%, it is high delivery. And most times, like I've said, you can give the high oxygen concentration through the oronasal area. You can use the oxygen mask. But for the low oxygen concentration, you can administer it using the nasal cannula, the transcatheter, and the nasal catheter, and so on. And that will take us finally to, okay, we also have respiratory stimulants. Example of respiratory stimulants is nicotinamide and oxapram. What do? They may occasionally lead to improvement in ventilation and obviate the need for assisted respiration, especially in patients with respiratory failure, which requires either intubation and artificial ventilation. So you use respiratory stimulants in such cases. And the adverse effects of this respiratory stimulant include vomiting, restlessness, and convulsion. For the respiratory drugs, we also have expectorant and cough suppressant, which we use for coughs. And the agents with expectorant properties as ammonium chloride and guanifacine, they are often included in cough mixtures. Most times when you buy a cough mixture, look at the content. You find ammonium chloride, you can find guanifacine in these cough mixtures. So most times, as you all know, cough might not be a disease entirely. It can be a protective mechanism that enables clearing of the airway. So it enable the clearing of secretions from the trachea and the bronchi. And drugs that are used for cough suppression, they are usually given in form of a sweet syrup. They are usually given in form of linctus. An example is codeine. That is why you see patients asking for codeine. They want to buy codeine. They want to use it to suppress their cough. So all these, they are used as cough suppressants. Thyroid agent. We did not discuss thyroid agent during the online facilitation, but this is an opportunity for you to just be aware of what is thyroid agent. You can take your time and go and read more on thyroid agent. We all know the thyroid gland, which is situated in the neck. The thyroid gland synthesizes, it stores, and it secretes iodinated amino acid hormones. The thyroid hormones regulate oxygen consumption and regulate heat production. It also synthesizes calcitonin, the thyroid gland. The secretion of the thyroid hormone, which is T4 and T3, is regulated by the hypothalamus and the pituitary gland. The thyroid gland could be subjected to some disorders in function, and it can be in form of either oversecretion or undersecretion, and that will take us to hypothyroidism and hyperthyroidism. When it is undersecretion, it is known as hypothyroidism, and for the oversecretion, it is known as hyperthyroidism. For the hypothyroidism, when you have undersecretion of the thyroid gland hormones, it can lead to what we know as cretinism in infancy. And in adults, it can lead to myxoedema or Hashimoto's disease in adults. So in such cases, what do you do? Because you have known it's an undersecretion of thyroid hormone, what do? You replace the thyroid hormone. An example of drugs that comes in this form include the L-thyroxine, which comes in tablet form. It comes in about 0.05 to 0.1 milligram. Then you can have L-thyroxine sodium, which is known as synthyroid sodium. It is the synthetic sodium salt of levothyroxine. We can also have leothyronine sodium, which is the synthetic sodium salt of levothyronine. It may be given as intravenous. It can be given intravenously, especially in emergency cases when patient is having myxoedema coma. And we can have LOTECH. It's an example of a thyroid agent which is used in hypothyroidism, and it usually comes in a mixture of levothyroxine and iothyronine. It comes in a ratio of 4:1 ratio. Then we can have, when you have hyperthyroidism, that is when you have oversecretion of this thyroid gland. What are the drugs you use in hyperthyroidism? You can use drugs like iodides, which example is potassium iodide or Lugos solution. You can also use thiourea derivatives, and these come in form of propylthiouracil, carbimazole, metimazole. Metimazole and carbimazole are very common ones that you can see. We can also, another preparation of drug used in hyperthyroidism can also be perchlorate, or which is an example is potassium perchlorate, and you can also have radioactive iodine. When you have excess thyroid hormone production, it will increase metabolism, and together will cause overactivity of the sympathetic nervous system, which can give rise to clinical conditions known as thyrotoxicosis or Graves' disease. At this junction, we have been able to carry out our online revision on from study session 1 to study session 9. Thank you all for your time and your attention. I wish you the best in your exams and continue to stay safe. Thank you.
Okay, that is the end of the PHA 302. So it is time for question and answer. Mr. Jude, your question.
Good day, Ma. Thank you very much for the eloquent and interesting lecture. How I wish we continue like this in the subsequent exams ahead. My first question is about the cholesterol lowering drugs. There was a time there was this publication that we even need more cholesterol in the blood than we thought, and then with the encouragement
I can't hear you well.
Egg. Hello.
Can you repeat that?
Can you? Can you hear me now?
Okay, what are you saying? You said there was a time, a publication.
Can you hear me now, Ma?
Yes, speak on.
I said there was this that is relating to cholesterol lowering medications.
Drugs.
You know,
okay.
They used to say when you have high cholesterol, it leads to hypertension, and after test, they require, they prescribe all these cholesterol lowering drugs. And then we used to counsel people then not to eat too much egg because it increases the cholesterol level of blood. And of recent time, there's a finding that we even need more cholesterol in the blood than we earlier thought, that one is encouraged to eat even more eggs to have more high cholesterol. So I have been thinking about it. I don't know whether you've heard such thing as well. So why the role of administering of cholesterol lowering medication now, as per in the treatment of hypertension? And my second question is relating to the administration of oxygen. I don't really understand when we say low rate and high rate concentration. Is it high rate when the amount delivered per minute is high, or you determine the high rate or low rate by the equipment you use, maybe the face mask type that is used?
Okay, thank you for your question. Concerning the cholesterol, I hope you know that we have both bad and good cholesterol. So like when I was saying, I said we have HDL, we have LDL, we have triglycerides. So we have good cholesterol, we have bad cholesterol. Before you can start a patient on a cholesterol lowering agent, it is important for you that you carry out the lipid profile. And this will help you to determine the level of various fats. When you carry out lipid profile, it comes in, the result comes in HDL, LDL, the amount of HDL, the amount of LDL you have in the bloodstream. So when we are talking about diet, you know, I first said it's not the drug that you first introduce. You first talk about the diet. And when you want to talk to the patient concerning the diet, you have to talk about introducing diet that is very low in saturated fat. So when they are talking about we need cholesterol in the body, it's not as if we don't need cholesterol. What kind of cholesterol are they saying we need in the body? So if you go back to read the research, the result of the research, they will tell you the type of cholesterol we need in the body. That's the reason we classify it as good and bad cholesterol. So you don't need bad cholesterol in your body. You need, if after you have carry out a test of your lipid profile and your bad cholesterol is high, definitely you must be on cholesterol lowering agents because of the risk of atherosclerosis. Then concerning the issue of oxygen,
Lost audio, please. Lost audio.
okay. The rate at which you deliver the oxygen to the patient will determine if it is low or high concentration. Like I said, when I was delivering my lecture, when the rate of the delivery is less than 35%, you can say it is low. And when the rate of delivery is more than 60%, you can say it is high. Then depending on the condition of the patient, that is when you know if it is high or low. And also the mechanism at which the way you use to deliver the oxygen. If it is either through catheter, that will classify it as either low or high. I hope I'll be able to answer your question.
Ogbu, Abigail, your question.
Good morning, ma. Thank you so much for the from degree centigrade to degree Fahrenheit and from degree Fahrenheit to degree centigrade. Please, I want you to throw more light on that. Then secondly, you talked about the anticholinergic drugs. You talked about its inhibiting involuntary muscles. Please, I want you to talk about its other actions apart from the issue of inhibiting muscles, human.
Okay, concerning the calculation, as you can see on the screen, next slide. Next slide. Next. Okay, when you want to do conversions, between systems. You are given a temperature in Fahrenheit, and you want to convert it to Celsius. So I said, in converting it to Celsius, you have to multiply it by 5/9 after you have subtracted 32. For example, if the temperature is 100 degrees Fahrenheit, and you want to convert it to to Celsius, you have to minus 32 from 100, and you multiply by 5/9. That is what I mean by conversion. So depending on how you are converting it, either you want to convert from, if you are converting from Fahrenheit to Celsius, but if you want to convert from Celsius to Fahrenheit, you have to divide. Is that taken? Then concerning the anticholinergic, are you, Abigail, can you hear me well?
Yes.
Concerning the anticholinergic, I have only discussed anticholinergic agents pertaining to respiratory system. That is why you cannot just know, even drugs comes in various drugs can perform various activities. For the anticholinergic agent, if you go and Google, if you go and browse, you see different actions of anticholinergic agents. But pertaining to respiratory system, that is what we have discussed. So if you want to know more about anticholinergic agents, you can go and read more about it.
Thank you very much, sir. Good morning, sir. Good morning, ma. Thanks for the wonderful lecture, ma. I have two questions. Number one, you talked about Z-track technique. You said it is normally used for it is administered when subcutaneous tissue is irritating or permanently stained. I want to understand how a drug stain
Oh, you did not hear me right. Hello, Ayobami. You did not hear me right. I never said when subcutaneous tissue is irritating. I meant when the drug you want to administer is irritating to the subcutaneous tissue. So there are two different things.
Okay.
So it is concerning the drug, not the subcutaneous tissue.
Okay, ma. The question is, how is a drug irritating to subcutaneous tissue? That's number one question, ma.
You have to know about the pharmacology of the drugs. That is why you must know about every drug you want to administer to your patient.
Okay.
You cannot just look at a drug and say, okay, this drug will be irritating to this tissue. You have to read about the drug before you administer.
Edit your question. Edit your question.
Hello. Good afternoon, ma. Thanks for the wonderful lectures. Hello?
I'm listening. Speak on.
Yeah, thank you, ma, for the wonderful lecture. My question is concerning the high concentration and low concentration method of administering oxygen. I want to know, is it that it depends on the disease condition of the patient or the amount of the oxygen concentration in the system that will not determine the types of method of administering this oxygen? That's what I want to know.
Madam Edith, it shows you are not following this class. When I was discussing oxygen administration, I gave you examples where you can give high concentration of oxygen. So go back to your lecture notes and study it.
How about your question?
All right. Good morning, ma. Thank you for the nice presentation this morning, ma. I have two brief questions, or three, ma. The first question, ma, when you talk about the pricking of the patient when making an attempt possible to insert possible cannula or administering IV medication, yet the nurse should not prick more than 3 times. If at all such happen to seek maybe help from other
practitioner.
I want to know if this principle mainly for nurses or all other hair care providers. Then the second question is on the steps in the nursing process, ma. I don't know, the 5-step mentions, if they are specifically for pharmacology when we are dealing with pharmacological issues, or if it is entirely on the nursing, because I don't know, currently I think we have 6 steps.
6 or 7.
6 steps in nursing process, but you listed to us 5. So I don't know if it's on this pharmacology. Then the last question, ma, on the, when you talk about the corticosteroid, ma, and hydrocort is one of the major drugs we use today, possible at time in the A&E. But down there on that IV administration of hydrocortisone, it said there that there could be a delay on the onset of the actions because the receptors of these steroids are found inside the cytoplasm. So, ma, but I'm then confusing me where we use this as one of the major breast health medications intervening in A&E. If you have something more like to throw to me, then for better understanding on why, even though it's one of the most common used drugs in A&E, but by what I'm seeing here, that because of the receptor where it's located in the cells, that the actions is not so. I'm a bit confused there, ma. Thank you.
Okay, starting from your first question on intravenous, okay, on pricking of patients, it does not only apply to nurses.
Yes, ma'am.
It applies to all medical professionals. I hope you all know, even if you are as a patient, when you are being pricked, it is usually painful. However, it's because nurses are still empathetic enough. When you are pricking patients, at least you still look at the face of the patient. But for we are more empathetic compared to other health care professionals. So, but because this lecture actually focuses more on nurses, that is why I'm talking about nurses. But it's a natural rule for all healthcare professionals. When you have pricked about 3 times in 3 different places, and you couldn't get it, it's better to get experts to help in that situation. Then your second question was on what?
The steps in the nursing process, ma.
The steps in the nursing process. Okay, like I've said, even on the slide, you will see that it is the steps in nursing process as applied to nursing. Okay, let me ask you, what are the steps, the 6 nursing steps in nursing process?
Yes, ma'am. We have nursing assessment.
Okay.
Yes, nursing assessment, the diagnosis, the outcome identification, the planning, implementation, and then evaluation.
Okay, out of these 6 processes you have mentioned, there's no process that you cannot apply to drug regimen.
Okay.
So the way you carry out your normal nursing process, you apply it to your drug administration. What is your third question?
Yes, ma'am. The third question, ma'am, is on the IV hydrocortisone, ma'am, or corticosteroids, ma'am, which is one of the common drugs in A&E. But I see to it that I talk about of the actions is delayed because of the cytoplasm location of the receptor. That is, the receptors are found in the cytoplasm. So the actions of these steroids can be delayed. So there is most at time not considered when we talk about emergency. But today we most use some of these drugs in the emergency room. So I don't know, if there's any light that you can help me throw more to this.
Concerning being delayed, you have to carry out more research. What time? You know, we are not specific with timing. That is why it is scientific. You have to be more scientific. Being delayed, what is the timing? Are you getting that?
Yes, ma'am.
Then the route of administration itself is very important when you are talking about being delayed or not being delayed. In emergency cases, most times, how do you give hydrocortisone?
Most times they are IV, ma'am. Yes, IV, ma'am, through intravenous route.
So it depends on your routes of administration at which you administer those class of drug that you to determine if it is rather slow or not. So we need more research to carry out on that, and you can start from you. So I'm encouraging you, since you are an A and E nurse, you can carry out the research on the interval at which this drug acts.
All right, ma.
Ajayi Omobosede.
Thank you very much for the wonderful, brilliant lecture, ma. I just want to reconfirm something that I heard you said, or probably I didn't hear very well, but I want to reconfirm. Did you say that needle one is pricked to during needle prick injection, one can actually contact malaria, syphilis, and then tuberculosis? That's my first question, because I think I heard something like that. Then
Yes,
the second
I said
one
that.
is, oh, thank you very much, ma'am. Then the second question is that when we are giving IM injection and we discover that it's on the nerves, as in we are able to withdraw blood before giving the injection, you said we should start the process all over again. Now, the process all over again, what does it entail? Does it mean that you just remove the needle and put a new needle, or you discard the old syringe and the drug? Then I want to ask, who is now going to bear the cost if the drugs in question now you have to throw everything away? Who is going to bear the cost? Should we explain the procedure? Tell the patient our mistakes and bear the cost, or who takes that responsibility?
Okay, thank you for that question. From your last question, if I guess right, during your school of nursing, you were taught how to administer injection. It is an error for you as a scientific nurse to insert your needle where you find blood or to prick a patient on a nerve. You know that is a bad error. So you don't even do that. So on who will bear the cost? It depends on the institution. But what I know is when you want to give an injection and you see that this needle is inside a blood vessel, you don't continue with the injection. You try and avoid medication because anything can happen. When you give a patient an injection on a nerve, this can lead to paralysis. Must you continue because of the cost? So that is why you were taught how to give IM injection. I know in school of nursing, they'll teach you quadrants. They will divide probably if you want to give it on the gluteal muscle, they will divide it into 4 quadrants. So the outer upper quadrant is where you give your injection. So when you do it right, you are not supposed to get into the vessel. Then your first question on whether you can get malaria, tuberculosis, syphilis through needle prick injection. It is very correct. A research has found out. So you can go extra miles to read more about how is it possible. But through research, it has been discovered that needle prick can cause malaria, especially from an infected patient. It can lead to malaria, it can lead to syphilis, it can lead to tuberculosis. Yes, I said it.
Thank you very much, ma'am.
Unwolu Precious.
Please, I'm still in the class. Go. I'll soon finish.
Mercy, ask your question.
Okay, good morning, ma. Thanks for that beautiful presentation. So, my questions are 2, and the third one is in the form of like contribution. So, firstly, let me start with the contribution. You said something that as nurses, we shouldn't quash tablets without first checking with the pharmacist. So I just want to make a comment that there are some cases whereby we need to administer drugs to patients that are not conscious, that they cannot actually swallow. So I think in that regard, we can actually do well by crushing the tablets after verifying with the pharmacist, like you said. So as nurses, we just need to use our critical thinking skills in some situations. It's not every time that we have to be checking with pharmacists before we can carry out some procedures that are meant for us. Then, so for the questions now, you said something about intramuscular injection, that we should not administer any injection that is more than 3 mils through IM. But considering this pre-charge regimen when you're managing pre-eclamptic patients, like it means you have to administer 5 mils into each buttocks. So in that situation, how do we do it? Do we need to start dividing it? Like, I don't know if you get my question.
Yes, I got your question.
If you look at the mils, it's certainly going to be more than 3 mils. And in a situation whereby you have to do in each buttocks at the same time. Then the second question is, you talked about the oxygen delivery, the concentration, that the high and the low. If I get you right, you said when we are administering oxygen at a flow liter that is higher than 5 or more, that's high concentration. And somebody said we can actually identify if you're giving high oxygen or low concentration through concerning that. Thank you, ma.
I didn't hear the last one. You can use check oxygen concentration through what?
Pulse oximeter.
Yes, pulse oximeter. Yes, you can do that. Most times when patients are even on oxygen therapy, you are always with your pulse oximeter. Most times we even place it on their hands to check the level of oxygen concentration. So you can use pulse oximeter to detect that too.
So how do we know if the patient is getting high concentration or low concentration using the pulse oximeter?
I told you the route where you can use to give a low concentration. If you were in class, I mentioned the route for low oxygen concentration, and I also mentioned the route for high oxygen concentration.
Yes, I heard so. But what I just want to clarify is there any way we can like identify if we are giving low concentration through the flow meter? Like through the flow meter, because I heard it said if it's above 5 is high.
And when it is below 5, what will happen?
So that will be low. I just want to confirm if
so
I
what are you asking again? Right. Then your first question. Your first question.
Yes.
What was your first question?
I was asking about giving intramuscular agents that are more than 3 mils.
Okay, when you give more than 3 mils, when condition of the patient warrants that you give 5 mils, like you have cited, you know, most cases is usually emergency cases. You don't have choice than to give. But the condition is that it will not be well absorbed like when you give 3 mils. It's not as if it will not work. But the absorption will be, yes. So that is the reason why I said the standard is this. But because you are doing something that is not standard does not mean it will not work. So you only have effect on the outcome.
Okay. Thank you very much, ma.
Hello, ma.
Hello.
Yes, ma. Please, ma, I want to ask a question based on the mode of action of beta-2 blockers, ma. We talked about beta-2 blocker in relation to insulin. You said they act on lining, on the bronchi and lungs. Please, ma, I want to get the actions well, ma.
The beta-2 blockers on what?
In relation to insulin, you were trying to explain something. So you talked about insulin, ma. When you were citing the sites of action.
I said when you are giving a patient, antihypertensive that contains both beta and alpha blockers, you should be very careful when you are dealing with patients with diabetes. Okay, this is because in diabetes, the beta blockers may block the release of insulin. So even when the blood glucose is high, you will have lower levels of insulin. So that is why you should be very careful. You should take history when you are giving patients with diabetes, beta and alpha blockers. Oluwaseun, your question.
Hello, ma.
Go ahead.
Can you hear me, ma?
Go ahead.
Okay, thank you. Yeah. Thank you, ma. My question is this: like when you were talking about the calculation of drug dosage, I noticed you didn't cite example, and some of us have challenges sometimes with calculations. I don't know if you can help us with one example if we should be expecting such in exam. Thank you.
Thank you for that question. Nurses are usually lazy when it comes to calculation. And you don't have choice to avoid medication errors. You just have to do calculations. That is why there's no way I can start giving you calculations through this platform. But I've given you equivalent of units that you can use to calculate. But even if you look at your manual, you see different examples of calculations. For example, okay, let me set an example for you. When you say, okay, paracetamol comes in 500 milligram tablets, you are to administer 1.5 gram to your patient. My dear sister, how many tablets will you give to your patient? That means since it comes in 500 milligram tablets, and you know that 1.5 gram is equivalent to 1,500 milligram, it means you have to give your patient 3 tablets. That will be equivalent to 1.5 gram. So that's an example of calculation. For more calculations, you can check your manual. Olaleye Mubarak, your question. Abigail, your question. For more questions and clarifications, you can send questions to your WhatsApp mail for more questions and clarifications, and you can contact me on my personal line for more questions and clarification. So for more questions and clarifications, you can contact me on my personal wall, 070-6109-4959. Again, 070-6109-4959. Thank you for your time. I wish you all the best in your exams.